So our first talk today is going to be by Dr. Paul Coe, and the topic is on non-invasive tests in metabolic dysfunction-associated steatotic liver disease, what to use and when to use. Thank you.
Thank you. Good morning, Arvind, and thanks everyone for joining us this morning. We are going to talk about non-invasive tests in what was formerly called non-alcoholic fatty liver disease. In all of our records, we're trying to transition to metabolic dysfunction-associated steatotic liver disease, or MASLD. It'll take us a few years to get there and say that reliably. Disclosures. So just start off with the case presentation. So this is someone that any of you might see in clinic, 59-year-old gentleman who comes in because they found steatosis incidentally on an ultrasound. He has metabolic risk factors, hypertension, hyperlipidemia, obesity. On exam, BMI 32. Exam unremarkable, but has central obesity. When you look at his blood tests, white count 4, hemoglobin 14, platelet counts a little low at 145,000. And you can see there his AST, ALT are a bit elevated. And bilirubin is normal, but still on the high side. INR is normal, and your ultrasound report shows a heterogeneous liver and a spleen of 13 centimeters. So the question is, we need to get an assessment of how does this person have fibrosis that's significant or not. And when you think about patients with MASLD or any other chronic liver disease that you might see in your clinic, the important thing historically now is that we're transitioning. And so this transition is from a specific fibrosis stage. And so I see many of people in the audience who are trained at my era or even after me. We used to, with hepatitis C, we used to have these grading scales. They were numeric, 1 through 4, 1 through 6, for different types of fibrosis if you use Ishak. These have largely been replaced with now advanced fibrosis, which is F3, F4, and those who have less advanced fibrosis, which can be F0 and F2. And for purposes of metabolic dysfunction-associated steatotic liver disease, or NAFLD, F2 fibrosis and above represents an inflection point, so that once you get to F2 fibrosis in an individual with MASLD, your risk of having further future hepatic events goes up significantly. So that's really the important key inflection point that we need to determine in our assessment of patients who have metabolic liver disease or really any other liver disease. So what have been our historical methods for assessing liver fibrosis? Well, liver biopsy for years we used, predominantly driven by hepatitis C, which, as all of you know, now has therapeutically largely been figured out, and we have excellent curative therapies. We still, because of the hepatitis C era, have derived some serum tests and formulas, and we're going to go over a few of these as well. There are also commercial tests, and we've now introduced elastography into our practice, and we have some office-based point-of-care tests, we have ultrasound-based tests, and we have MR-based tests as well. And all of these now have really supplanted liver biopsy. Liver biopsy hasn't gone away, but it's an imperfect standard as well. And also, patients aren't particularly fond of this. So when we see a patient in clinic, you can immediately, from the testing that you have, that you probably got in the referral packet, acquire some information about this person's degree of fibrosis. So some of the things you can look at immediately are the AST and ALT ratio. So if it's greater than 0.8, this suggests alcohol, or if you don't have alcohol use involved here, then this really starts pointing toward more advanced fibrosis. In addition, a platelet count, if it's less than 150,000, and that's usually the cutoff for most laboratories, if it's less than 150, you need to be thinking this person may have significant portal hypertension or advanced fibrosis. And of course, you can look at an ultrasound report if you see splenomegaly. If your radiologists are sufficiently compulsive in their reports, many of them will include a portal vein diameter, and if you see it's above 13 millimeters, that's also an important caveat for portal hypertension. And of course, sometimes on the ultrasound reports, you can bring them up in your EHR, and you see this nodular liver surface here. That's really suggesting more advanced liver disease. If you see these collaterals or splenomegaly, well, then these individuals likely have cirrhosis or severe advanced bridging fibrosis. We can use the simple blood-based biomarkers, and again, these evolved initially with viral hepatitis. There are 2 that are out there, and we have shortcuts in our EHR where you can just do a .fib4 or .apri, and we can just get these calculated. They're based on AST, ALT, platelet counts, and you can use these FIB4s, and in fact, our NAFLD practice guidance actually uses FIB4 as the initial screening test. If you make this calculation and you have a test that's less than 1.3, this really excludes severe fibrosis with high negative predictive value. That is, you're in good shape here in making sure that these individuals aren't going to have meaningful fibrosis. In addition, if the value is above 3.25, this really points that this person has significant advanced fibrosis. Now, these tests don't apply to everybody. They were developed for hepatitis C and HIV, hepatitis C co-infection. They also have been validated in hepatitis C populations and in those who have MASLD as well. If you're younger, it's not as accurate. And we, again, in our practice guidance, as I will show you, it's the first-line test that we use. The AST platelet ratio index is also helpful, again, predominantly used for viral hepatitis, and a value less than 0.5 really very nicely excludes cirrhosis as well. However, all of these tests fall down in indeterminate ranges, and they have indeterminate ranges, which is why we sometimes have to combine these with other tests. Two other tests that have come to the forefront are the NAFLD fibrosis score, and this is from the late Paul Angulo, and this is a test that looked at, in addition to simple blood-based markers, it took into account your age, BMI, albumin, platelet count, and you could actually, with reasonable accuracy, determine whether these individuals have low fibrosis, F0 to F2, intermediate, which is always the area where you need additional testing, as well as advanced fibrosis. Similarly, Ray Kim at our institution, Stanford, came up with a SAFE score, and it's a similar concept here. You use BMI, diabetes, globulin level, platelets. Not all of these are readily available, but you can order them. And this is a primary care test, and if you have a SAFE score less than 0, this has a high negative predictive value to recognize low-risk metabolic dysfunction-associated steatotic liver disease. Why is this important? Because up to 1/4, 1/3 of the population has MASLD compared to just depending on how it's defined, and in other countries can be as high as 40%. There aren't nearly enough of us to go around to evaluate all of these individuals, and it's very important that we quickly identify individuals who don't need extensive evaluation, still address cardiovascular metabolic risk factors, et cetera, but we then can devote our time to those who have more actionable liver disease. There are also complex biomarkers, and here we have ALT, AST, and you can see here hepatic function, matrix production, scar tissue, proteins, and these have been validated for specific liver diseases. One of these tests is FibroTest. It's been around for many, many years, and this test looks at a variety of inflammatory fibrotic markers in addition to bilirubin, and it gives you a very nice linear fibrosis regression here, and you can get a fibrosis score. Caveat here, if you have Gilbert syndrome, the bilirubin is high, it will automatically make the results not valid, and so this is one of the very straightforward consults we see. Young person comes in with Gilbert syndrome, bilirubin's 2, and it says you have F4 fibrosis, and you just simply do an elastography, reassure the patient, and they're quite satisfied. So it can't be used in those with elevated bilirubin. Some of you have used maybe in the hepatitis C era of FibroSpect, which is a similar test, and it's also one for non-alcoholic steatohepatitis, or now it's MASH, but it's the same thing. You can get low or high fibrosis levels. And finally, now there are blood-based biomarkers, and this is one that was recently improved, enhanced liver fibrosis, and this looks at a variety of tissue matrix proteins here, and you can actually cut and use this test to produce and predict clinical outcomes in those with MASLD and in other liver diseases as well. And it's actually been validated in a variety of liver diseases, and in an effort to replace liver biopsy as a surrogate for MASLD, actually this is one of the biomarkers that was pre-qualified to move forward for further assessment. Let's turn our attention to elastography, because this is the other test which has really complemented some of these serum markers and allows us to avoid liver biopsy. So many of you in your offices may have vibration-controlled transient elastography, that's FibroScan. If you order an ultrasound, there are two types of ARFE, or acoustic radiation forces, shear wave or point shear wave elastography that you can obtain. And of course, the gold standard, although a bit more expensive and involved, is MR elastography. And these can be performed serially, not the morbidity associated with a liver biopsy. There is a failure rate associated with elastography, particularly those with very high BMIs, and this is a problem that we don't have with our serum tests, although each of these tests certainly has drawbacks. So here is vibration-controlled transient elastography, and you can see here that you take this probe here, and it measures about 3 centimeters of liver. You have the transducer and the vibrator, and you get this very nice output here. There's an extra large probe if the skin-liver capsule distance is greater than 25 millimeters, 2.5 centimeters. And what this generates is a fibrosis score, and it also, because it can measure the extinction of the wave as well, you get a nice assessment of what they call controlled attenuation parameter. This gives you an approximation of steatosis as well. And this can be done in the office, have to be fasting for 3 hours. But if you can get this, it's a nice point of care test, and patients really appreciate that they have an approximation of their fibrosis and steatosis on the way out of the office. It's non-invasive, less expensive, and you can use it serially. Again, there are disadvantages, high BMI. You need to have, there is a learning curve with this, and it's really best at the lower end and the higher end. Intermediate levels can be a bit tougher to assess in this case. Also, inflammation can drive this. So, for instance, if you have a severe inflammation in the liver, your elastography score is going to be very, very high. And so you'll need to assess these individuals afterwards. This was classically shown in hepatitis C, where we had high elastography scores. You cure the hepatitis C, AST, ALT come down, and the fibrosis assessment level, the score will come down, but indeed the fibrosis still persisted. So this is a caveat with a FibroScan. In addition, there are cutoffs according to the various liver diseases. Each one is slightly different. Cholestatic liver diseases have higher cutoffs, but in general, anything above 12 means significant fibrosis. Similarly here for ultrasound, you can see here acoustic radiation force impulse, and you can see here you can just pick your point here, and there's also a region of interest here, and you can get a very nice fibrosis assessment here, and this works just as well as FibroScan. Elastography, which is what we use quite a bit at our institution, you have an MR, you don't need contrast, but you have this active driver and this passive driver you attach to the chest, and they generate these impulses here. And the nice thing about MR is, unlike elastography that is shear wave or vibration controlled, you get a much larger region of interest here. And one of the things that is very interesting we found in MR is you can see the fibrosis is not uniform in the liver. It's the most accurate way to detect fibrosis, and though it's much more costly than vibration controlled or ARFI and serum tests. But if you really need to know, this is the best test. And all of these tests seem to work quite well. This is just some comparison of techniques. You know, vibration controlled elastography, FibroScan has been validated. There are some indeterminate cases. It hasn't been so much studied in the other forms of elastography. Also, the elastography scores that you get, they are not interchangeable. So this is something else. Patients will come to you and they'll say, hey doc, my FibroScan value was 7, then I got an MR, and it was only 4. Did I get much better? You can see here in general, MR elastography values are about 1/3 that of vibration-controlled elastography, and then acoustic radiation forces uses as meters per second, so they're not comparisons apples to apples. So you have to be careful there. And again, cholestatic liver disease, hepatic congestion can all affect these. There are combinations of markers as well. And so these are also being explored, FibroScan with AST, MR with AST, MR combined with FIB4. So for the NAFLD, our patient, so how do we approach these individuals? Well, we stratify initially with biomarkers, and then you can move on to other complementary testing. So someone comes in, you suspect MASLD, fatty liver, you can check a FIB4. And this is what the practice guidance says. If it's less than 1.3, then these individuals, you still address their metabolic risk factors, the 5, triglyceride, cholesterol, BMI, diabetes, etc. And you can just have your family physician or primary care person reassess these, get a FIB4 every couple of years. If the FIB4 is greater than 1.3, then you need some additional testing, and you complement this with elastography. Or you can send off one of these serum markers such as enhanced liver fibrosis. And then this helps provide a secondary risk assessment. And again, if your ELF or your FibroScan is high, then you direct these individuals to your care, where you have to decide whether or not a liver biopsy is required. We will have therapies for MASLD hopefully within the next year, and these who have meaningful fibrosis will need interventions, and nonetheless, they all need some lifestyle interventions, and we get to liver biopsy eventually. And so it's a combination of non-invasive testing. As I said, we have these now pre-qualified biomarkers, and there are 3 that are going to move forward: NIS4, ELF test, which I've talked about, and this fibrometer, VCTE, which is a serum marker with FibroScan. So all of these are going to move forward, and again, the goal is to replace liver biopsy ultimately as an endpoint, which has its own shortcomings. So if somebody is referred with abnormal liver tests and needs a fibrosis assessment and you suspect MASL D, I suggest you use a blood-based biomarker with a high negative predictive value, and these are FIB4 AST platelet ratio index, but you can use really any of these. And if they're low risk, you address the primary liver disease, but you can just follow them. If it's intermediate or indeterminate, high risk for fibrosis, you need to confirm with a second test. And if it's concordant, you address the primary liver disease, liver biopsy if required, advanced liver disease management if required. If you're still indeterminate, your serum test says one thing, elastography says another. I like an MR elastography as the tiebreaker, and you correlate this with your high BMI serologic evaluation. You may come to liver biopsy, you may be satisfied that the MR gives you the answer. And again, if elastography fails, you need to go to a liver biopsy. Going back to our patient, this person was very interesting. So you can see we suspected cirrhosis, platelet count was low, FIB4 was high, but we did a FibroScan, which was actually kind of low, 7 kilopascals. I thought that's a bit unusual. So we did an MRE on this person. And it was very interesting, as I'll show you here. He had cirrhosis on biopsy, but high fibrosis, low fibrosis, and if you look at the liver, just depending on where you did your region of interest, he had variable levels of fibrosis. And this is something we occasionally see. Here's his liver, but actually the fibrosis level was variable. And so depending on where you put the probe, you might get a slightly different area. And so again, remember, elastography shows us that fibrosis is not always necessarily uniform. In this case, we got a biopsy-proven cirrhosis. So in conclusion, simple and complex biomarkers with high negative predictive value can be used to assess fibrosis and MASL D. Use all of the tools you get in your initial consult, add your imaging, add your other simple and complex biomarkers, and complement it with elastography. If you combine these tests, it's better, and if you have indeterminate results or other diagnostic dilemmas, you will need to get to biopsy. It hasn't gone away. It's an imperfect standard as well. And again, we hope that improved biomarkers for MASL D and other diseases are going to be available in the future so that we can do fewer biopsies, and I know our patients will appreciate that as well. I'll stop here, and again, thank you so much for the opportunity to spend the morning with you.
Thank you so much for that great talk. Like you said, NAFLD, MASLD. I think we use the terminologies in our notes, both terminologies for now, until MASLD becomes more common.
Okay, the next speaker is Kirti Shetty. So Kirti and I go a very, very long way. So she was my senior fellow at UConn, and I was struggling to write a case report for GI endoscopy. Those days, she was writing a review article for gut on the genetics of hepatitis C. So I got a very, very good memory, and she would encourage all the very simple research that a fellow would do. But you know that she was going to have a very, very bright career and one of the most intelligent people I've seen in my profession. So such an honor to have Kirti again back in Orlando. And she did predict me that I would be a better politician than a gastroenterologist even those days.
Well, thank you, Shyam, for that kind introduction, and thank you to the organizers for having me here, and to all of you for sharing your weekend with us. So my task over the next 15 minutes or so is to talk about abnormal liver tests as they occur against a background of inflammatory bowel disease. So this is an outline of my talk. We'll just define these abnormal liver tests and talk about the types of abnormalities, discuss the prevalence of these elevated liver enzymes, ELE as they're known as, in IBD, and then briefly touch upon the causes of ELE and the differential diagnosis and approach. Just a one-slide refresher on these abnormal liver tests, which are really liver injury tests as they relate to these liver-associated enzymes. You're all familiar with them: hepatocellular enzymes, the aminotransferases, AST and ALT, which should be less than 40 in most labs, more specifically less than 30 in men, less than 19 in women. And then the cholestatic or biliary enzymes, alkaline phosphatase, GGT, and 5' nucleotidase. The term liver function tests is inaccurate because these enzymes don't really reflect liver function and should not be used any longer. It is important to remember that significant liver injury can exist despite normal liver-associated enzymes. So what is the significance of these elevated liver enzymes in IBD? Well, the prevalence of these is kind of all over the map depending on the kind of study that was done, the definitions used, and so on. But the prevalence ranges widely from about 18 to 36%, even 50% in some studies. But up to 2/3 of these are transient, and they resolve spontaneously. Elevated liver enzymes, though, in IBD are associated with an increased risk of death. And this particular study from the Mayo Clinic showed that the risk of death may be approaching 5. The hazard ratio was 4.8. So it's really not a benign association and maybe a surrogate of more advanced IBD. This is a retrospective cohort study from San Francisco General and was characterized by a very long follow-up, 25-year longitudinal follow-up. And these were the associations that emerged from this. It seemed to be associated with higher BMI. Ulcerative colitis was actually protective in this study. And again, higher mortality rates were noted in those who had persistent elevations of liver enzymes. The pathogenesis of hepatobiliary disease, as with other extraintestinal manifestations of IBD, is not very clear, but there is a definite genetic correlation, and there is a significant overlap between the genetic risk loci noted in various other EIM as well as IBD, and these are the risk variants that have been identified specifically for PSC. The role of the gut microbiome has gained a lot of attention over the last few years. Gut dysbiosis seems to activate intestinal immune cells that migrate to the liver and set up inflammation. And there's also a molecular similarity that's been noted between the antigens present on the gut microbiota and non-microbial epitopes that are present on hepatocytes. Activation of the immune system also plays a very important role. In IBD, inflammatory T cells are recruited into the intestinal wall through an interaction of integrin with this particular cell adhesion molecule, MAdCAM-1, and ectopic expression of MAdCAM has been reported on hepatocytes. Environmental risk factors, the association is less clear. So some of the extraintestinal manifestations are more prevalent with a higher exposure to tobacco. In others, tobacco use is actually protective. So how do you approach these patients who have elevated liver enzymes against a background in IBD? The first question to ask, and this is where history taking is really important, is to figure out whether the abnormality is related to the inflammatory bowel disease itself or whether it's treatment related, because almost all of the treatments that are used for IBD do have liver side effects. Of the IBD-related liver diseases, MASLD, metabolic dysfunction-associated liver disease, previously known as NAFLD, is the most common. PSC, of course, is the most typical, and autoimmune hepatitis also occurs with a fair frequency. Treatment-related ELE may represent either drug-induced liver injury. It may be due to the immunosuppressed state itself that's induced by many of the treatments for IBD, and this can lead to reactivation of hepatitis B, CMV, APV, etc. Reactivation of tuberculosis very rarely causes elevation of liver enzymes. It can do so by granulomas within the liver, but more commonly, anti-TB therapy, as you know, is quite hepatotoxic. Granulomatous disease, such as histoplasmosis, and rare malignancies in neoplasms can also occur. So primary sclerosing cholangitis is probably the liver disease that we all associate most frequently with IBD. It is the typical liver disease. And in terms of its prevalence, it affects about 5%, 7% of those with ulcerative colitis, less common in Crohn's disease. And in North American populations, the prevalence is about 8 to 14 by about 100,000 population. It is a very rare disease, even though it doesn't seem so at most centers with active liver programs. And so each year it's about less than one case per 100,000 patient years. It's almost never seen in children. And it seems to be associated with pancolitis and ulcerative colitis, male gender, and non-smokers, those who've had prior appendectomies. So the diagnosis of PSC is based on classic cholangiographic findings. And MRCP is really the drug of the investigation of choice. It is cost-effective, very accurate, and non-invasive. There was an interesting study, a very small study, of 32 patients with IBD who were systematically screened by MRCP and were found to have a surprisingly high prevalence of PSC, about almost 8%. And 2/3 of these had normal liver-associated enzymes. ERCP, of course, has better sensitivity for subtle bile duct changes, and therapeutic intervention is possible. Liver biopsy is really not necessary unless there's a suspicion of an alternate diagnosis, but if it's done, you will see these pathognomic periductular fibrosis, the so-called onion skinning around the bile ducts. So the EASL criteria summarize this. To make a diagnosis of PSC, one is required to see chronic cholestasis without another etiology and typical cholangiographic findings. Serological testing is done, but is not very helpful. P-ANCA is the most commonly encountered abnormality, but ANA and anti-smooth muscle antibodies are also seen. The pathogenesis of PSC is uncertain. These are the various theories related to chronic bacterial portal bacteremia, ischemia of the biliary tract, and genetic predisposition to PSC is very common. There's an 80-fold increased risk in first-degree relatives. And the largest GWAS study actually found 16 known PSC risk loci, and 6 of these had a stronger association with PSC than with IBD, suggesting that the predisposition to PSC is somewhat different than with IBD. The role of gut microbiota is somewhat unclear. These 3 genera are overrepresented in PSC, but it's not really clear whether these represent a cause or an effect. There are just some variant forms of PSC that I wanted to mention. Small duct PSC is characterized by a normal cholangiogram. In these patients, you see a cholestatic pattern, you can see histological findings. It's often very confusing because it is important to rule out other causes of cholestasis. And the EASL guidelines actually recommend genotyping for this particular genotype, the ABCB4, which is also associated with progressive familial intrahepatic cholestasis. Small duct PSC is more frequently associated with Crohn's disease and actually seems to be a precursor to classic PSC in about 12 to 23% of cases. It has a better long-term prognosis, and to date, no cases of cholangiocarcinoma have been identified. Another overlap form to be aware of is PSC in autoimmune hepatitis, which is more common in children and in young adults. And these patients benefit from immunosuppressive medicines, so it is important to identify them. And again, the prognosis is better than with PSC alone. A PSC mimic that is often seen is IgG4 cholangitis, which is defined by increased serum IgG4, infiltration of the biliary tract by these IgG4 expressing plasma cells, and preferential involvement of the extrahepatic versus the intrahepatic biliary tree. It's frequently associated with other fibrotic pathologies, such as autoimmune pancreatitis. And again, very important to identify this because these patients do respond quite dramatically to steroids. So changing gears slightly, MASLD is actually the most common liver disease seen in IBD. And again, the prevalence varies depending on how the diagnosis is made, but it's thought to affect about a third of all individuals with IBD. The incidence rate is actually quite high, almost 3 times that in the general population, of which 7.5% in one study went on to develop advanced liver fibrosis. In contrast to the general population, MASLD does not seem to be as clearly related to metabolic syndrome. And in fact, the individuals with IBD who have MASLD are much more likely not to have features of metabolic syndrome. Instead, it is related to the duration and the activity of the IBD. And it has been postulated that some of the treatments used for IBD, such as the anti-TNF-alpha agents, may be protective because they reduce steatosis and also increase insulin signal transduction. Again, the pathogenesis is not very well understood. As with everything else, the gut microbiome is thought to play a role. Immune activation, underlying inflammation related to the IBD is thought to drive fatty infiltration of the liver. I wanted to just talk about these particular liver diseases that are specific to Crohn's disease, in contrast to ulcerative colitis. Granulomatous hepatitis, it affects less than 1% of those with IBD, very uncommon. Hepatic amyloidosis, and this is particularly seen in those who have very active Crohn's disease with infectious complications, and pyogenic liver abscesses, which are usually monomicrobial in contrast to the commonly seen liver abscesses. Moving on then to hepatic complications related to treatment. The classic liver complications are seen with sulfasalazine, which is no longer used, mesalamine and oxalizine, which lack the sulfonamide group, are rarely associated with immunoallergic hepatotoxicity. Drug-induced liver injury is also seen with thiopurines, azathioprine 6-MP, and interestingly, these are associated with vascular lesions. 3 mechanisms are noted with these anti-TNF agents: autoimmune hepatitis, cholestasis, and hepatocellular necrosis. The anti-integrins and talazumab has been associated with hepatotoxicity, briefly withdrawn from the US market. Vedolizumab is actually very safe for the liver. So this is just a summary of medication effects. Another thing that we have to worry about is risk of viral hepatitis activation, and this occurs both in those with chronic as well as cleared hepatitis B. And the risk of activation as reactivation is related to whether patients have active hepatitis B or whether they have cleared it. It's also related to the type of treatment that is used. So as you can see from this chart, the risk is highest in those who are given high-dose corticosteroids and those who have active hepatitis B. So in terms of approaching elevated liver enzymes in IBD, the first question to ask is whether this is a temporary problem, whether it has occurred in the setting of flare. If so, and if these liver numbers are normal, in 3 months, you can stop a workup. If the elevation is persistent, then you need to define, is this hepatocellular or cholestatic, and do the workup serologies, MRI, MRCP, Liver biopsy is usually not required unless other causes of liver disease are suspected. So in summary, IBD is commonly associated with liver dysfunction. MASLD is the most common. PSC is the most specific. Drug-induced liver injury must be considered. Early diagnosis is very important as it affects future clinical care. And this is truly a condition where management involves both hepatologists and gastroenterologists. Thank you for your attention.
Thank you so much, Dr. Shetty. Our next talk is by Dr. Patrick Kamath. So Dr. Patrick Kamath is the Professor of Medicine and Gastroenterology and Hepatology at Mayo Clinic in Rochester. He has been there for over 25 years. For most of us in the liver world, we know that Dr. Patrick Kamath was the main brain behind the MELD score, which we still use and is one of the most important aspects. In addition to that, he has contributed in almost all aspects of liver diseases, acute and chronic liver failure, MASLD, alcoholic hepatitis. He has over 300 publications. In fact, one thing I wanted to share was I had two mentors I had during my training, and they inspired me to do hepatology, and they were really great. They both had one thing in common. They were both trained by Dr. Kamath. There's a lot of people I've met in the hepatology world who have been trained by Dr. Kamath, and I'm very, very thankful that he agreed to come here today and give us a talk. Thank you so much.
Yeah. Thank you so much, Arvind, and thank you, Shyam, for inviting me. And privileged to share the podium with Kirti and Paul. Acknowledge use of some slides from my colleague from Barcelona, Pere Gines. In this talk, I'll try and go over the scope of the problem. How common is AKI? What is the spectrum in cirrhosis? So what should you be thinking of when patients are admitted? The pathophysiology of hepatorenal syndrome, how you approach and diagnose these conditions and manage them, and finally some take-home messages. So first, how big is the problem? So this study shows you the percentage of patients with acute kidney injury in hospitalized cirrhotics is increasing. So approximately 1 in 4 of your patients hospitalized will have acute kidney injury. And when they have acute kidney injury, it's going to be more expensive, and they're going to stay in hospital longer. What are the types of kidney injury these patients are going to have? So most common is hypovolemia. That's by far the most common. Then there's acute tubular necrosis. Hepatorenal syndrome is less likely, 20 to 25%. And also remember, there are other causes. Nephrotoxicity, they may be on non-steroidals, contrast, antibiotics. They can have parenchymal kidney disease, and sometimes they have a combination of these. So to summarize the scope and spectrum, hepatorenal syndrome accounts for only about 20 to 25% of all your patients with acute kidney injury. When patients have acute kidney injury, it's more expensive, and they're going to stay in hospital longer, and hypovolemia is going to be your most common cause of acute kidney injury. Now, why do you get hepatorenal syndrome? So let's go over the pathophysiology here. So in cirrhosis, there's an increase in intrahepatic resistance because there's fibrosis, and there are also vascular factors. That increase in fibrosis gives rise to an increase in sinusoidal pressure, so that is portal hypertension. For reasons we won't get into, there's also vasodilatation because of decreased arterial resistance systematically. So the same blood volume is now flowing through a wider vascular space, and the kidney perceives this as a decrease in the effective arterial blood volume, and so the kidney tries to retain sodium and water by activating neurohumeral systems. So sodium and water is retained, and that is compartmentalized to the peritoneal space as ascites. Now, when liver disease gets worse, there is more vasodilatation, so further decrease in the effective arterial blood volume, more activation of neurohumeral systems, more sodium and water retained, and then you get refractory ascites. Further, as the liver disease gets worse, there is intense renal vasoconstriction, and therefore you get hepatorenal syndrome. So to summarize all this, renal dysfunction and cirrhosis starts off with vasodilatation, a decrease in the effective arterial blood volume, and activation of neurohumoral systems. And this gives rise to three manifestations. There is sodium retention, which gives you ascites. There is renal vasoconstriction, which gives you hepatorenal syndrome. And there's water retention, which gives you hyponatremia. So what is the message here? If you have hepatorenal syndrome, patients also have sodium and water retention. So if the patient does not have ascites, this is not hepatorenal syndrome. If the patient does not have hyponatremia, this is not hepatorenal syndrome. Okay, so this is a very important take-home message. So how do you approach and diagnose these patients? So the question is, when are you going to measure kidney function and how often are you going to do it? How? The fancier ways are glomerular filtration rates, but these are not routinely done. Cystatin C, MDRD are indirect calculations. The one that you have is imperfect, but still the best we have. So we're going to monitor kidney function with serum creatinine. How often do you want to do it? If the patient has compensated cirrhosis, you don't need to do it too frequently, maybe twice a year sufficiently. If they have compensated cirrhosis and renal function is worse, this is chronic kidney disease from mast cell cirrhosis. On the other hand, if they're decompensated and they are outpatients, measure maybe every 2 to 3 months, but anytime you find ascites is getting difficult to control, check the creatinine in these patients. In patients, it's different. When they hit the floor, check the creatinine and measure it, and maybe check it every 1 to 2 days. And when they get to the ICU, at least once a day, perhaps twice a day. So that's how you're going to measure renal function. And how are you going to define that? The definition of acute kidney injury is an increase in serum creatinine of 0.3 in 48 hours, or serum creatinine greater than 50% from baseline. Okay, so it's just 0.3. And then you further stage it. Stage 1 is the creatinine has gone up, but it's less than 2 times from baseline. If it's then less than 1.5, you call it stage 1A, and if it's greater than 1.5, it's stage 1B, and I'll go over an example a little later. Stage 2 is easy. If it's double, that's stage 2. If it goes up 3 times, it's stage 3. So that's how you're going to stage. So you've diagnosed acute kidney injury and you've staged it. So let's take some examples, okay? Patient starts off with 0.7 baseline. At admission is 2.6, so it's gone up more than 3 times. So this is stage 3 acute kidney injury. Baseline was 0.9. Now it's 1.2, so it's gone up by 0.3, so it's acute kidney injury. It's less than 1.5, so it's stage 1A. Start off with 1.8, went up to 3.2, so it has gone up, but not quite double, so it's stage 1. It is more than 1.5, so it's 1B, but the baseline creatinine was elevated, so this is stage 1B on chronic kidney disease. So this is how you're going to make the diagnosis. But sometimes it's difficult. You don't have a previous serum creatinine. They come in with 2.5, then you're never quite sure. That requires more investigation. So these are the diagnostic criteria for hepatorenal syndrome. Patient has to have cirrhosis with ascites. Serum creatinine has to go up greater than 0.3. You want to rule out other causes of acute kidney injury. So you replace volume. You've replaced volume for 2 consecutive days, and the creatinine is still not better. So you've ruled out hypovolemia. No shock. Acute tubular necrosis less likely. No nephrotoxic drugs. And then you look at the urine examination. No signs of structural kidney injury. No hematuria, no proteinuria. You rarely have to do an ultrasound, but the ultrasound is normal. So essentially, hepatorenal syndrome is acute kidney injury, and you've ruled out all other causes. So it's a diagnosis of exclusion. So what precipitates hepatorenal syndrome? Vasodilators, large volume paracentesis infection, that increases vasodilatation. That decreases the effective arterial blood volume. diuretics, diarrhea, hemorrhage, again decrease volume. Those will activate neurohumoral systems. You get renal vasoconstriction and renal dysfunction. Don't forget non-steroidals. Non-steroidals cause intense renal vasoconstriction, and therefore, try and avoid all these factors because otherwise the patient will end up with hepatorenal syndrome. So now you've diagnosed hepatorenal syndrome. So what are the general principles of management? First question is there acute kidney injury and what is the stage? And I told you greater than 0.3 and stage. Stop diuretics. Look for triggering factors. Most common is going to be infection, hypovolemia. Look for those factors in these patients. Give albumin if the serum creatinine is greater than 1B, so greater than 1.5, and I'll go over an algorithm in this. Don't overuse albumin. Patients are prone to get pulmonary edema, so 48 hours of 1 gram per kilogram per day is probably sufficient. Kidney injury, these are patients who are sick. Sometime consider evaluation for liver transplantation, and some of these might actually require ICU admission. So this is how you would manage them. Patients have cirrhosis, so consider liver transplant. That's the definitive treatment of hepatorenal syndrome. They have low volume, so you will give them albumin. They have vasodilatation, so you will give them vasoconstrictors. So this is the basis for management of hepatorenal syndrome. The current guidelines of both the European Society and the American Society is to use a combination of terlipressin with albumin. Note here, they recommend a continuous infusion, which is actually safer, though the packet insert will tell you to give 1 milligram 4 times a day to start off with. How effective is terlipressin? These are the results of the different studies. Panel on the left, treatment response percentage, and on the right is 3-month survival. So you can see about 40 to 50% will respond to terlipressin as compared to placebo, but overall survival is at 3 months is not that much better, so consider liver transplantation in these patients. So a few tips for those who have not used terlipressin. Most important, hepatorenal syndrome is not that common. There's going to be other causes, so make absolutely sure your diagnosis is right. So confirm. Start with 2 milligrams as a continuous infusion. Albumin, 1 gram per kilogram on day 1, and then 20 to 40 grams per day on subsequent days. Watch very carefully. Patients get fluid overloaded, so if possible, monitor CVP, but otherwise monitor them very carefully. If they are volume overloaded, stop the albumin, give furosemide, and then continue terlipressin. So watch for volume overload. Check for side effects several times per day. They get cold extremities, they get digital ischemia, they get cardiac arrhythmias, and I actually saw this patient in Spain with a tongue sloughing off from intense vasoconstriction. It's a very good drug, but be very careful about how you use it. Be very careful. And you're going to monitor efficacy of treatment with serum creatinine. So the effect is slow, so it's going to take at least 2 days when you increase the dose to see any effect. So watch for 2 days. Decrease in serum creatinine by 25% from baseline. Continue the same dose. If it does not decrease, go up on the dose. So you started with 2, go to 4 after 48 hours, go to 6. Maximum period is going to be 2 weeks. If the serum creatinine is coming towards baseline for 2 consecutive days, you can stop the vasopressin. So remember, don't use the same dose for everyone. Terlipressin and albumin is a very individualized, it's a very personalized treatment. You will also consider renal replacement therapy in some of these patients. So if they have acute tubular necrosis, determine, are they a transplant candidate or not a transplant candidate? Transplant candidates will have renal replacement treatment until transplant, and at that time they may require both a kidney and a liver. If you're not a transplant candidate, limited duration of renal replacement treatment. Hepatorenal syndrome, transplant candidate, renal replacement for sure as a bridge to transplant. Not a transplant candidate, be reluctant to recommend renal replacement treatment. Generally, no. There's the occasional patient with alcohol-related hepatitis whom you suspect maybe has sepsis too, they may benefit from renal replacement treatment. But often you're not quite sure, is this acute tubular necrosis or hepatorenal syndrome? Again, determine transplant candidate or not. Transplant candidate, we will continue renal replacement treatment. Not a transplant candidate, will give a shorter trial of renal replacement treatment. So your decision to initiate renal replacement treatment is on the etiology of acute kidney injury and their transplant candidacy. So finally, take-home messages. How do you approach these patients? You have a patient, creatinine has gone up greater than 0.3, but less than twofold, and the creatinine is less than 1.5. So this is AKI stage 1A. First thing is risk factor management. Stop beta blockers, hold diuretics, volume, make sure about infection. And if they've resolved that, monitor them. You don't need to do much more. On the other hand, if they've not resolved, then you have to give albumin for 2 days. Again, when you give albumin, be careful. Check volume status carefully in here. On the other hand, if the patient came greater than 1A, so that is 1B, or 2 or 3, you will give albumin right away. If they resolve after 48 hours, monitor. If they've not resolved, look at your urine biomarkers. Your urine should be clean. If it is not, this is likely acute tubular necrosis. Renal replacement treatment will be on an individualized basis. Urine clean, this is likely hepatorenal syndrome, vasoconstrictor therapy and albumin. If you're not sure, again, vasoconstrictor therapy and albumin, and consider renal replacement treatment on an individualized basis. And finally, do not forget that these patients are potential candidates for liver transplantation. Thank you.
Thank you so much, Dr. Kamath. I think the most important point is that only 1/4 of these patients actually have hepatorenal syndrome. So terlipressin should be carefully used for patients who actually have hepatorenal syndrome. So our next talk, again by Dr. Paul Coe. It is an important topic for hepatologists, gastroenterologists, and endoscopists. It is thrombocytopenia in patients with cirrhosis undergoing elective procedures, the clinical significance and treatment options.
Great, thank you so much. There we go. So we're going to talk for a few minutes about something that happens to us. Sometimes it happens the morning you're doing procedures, and this is how you address thrombocytopenia in patients with cirrhosis undergoing elective procedures, significance and treatment options. So disclosures, so let's start off with a case. So this is one that I had. So this is a 56-year-old female with Wilson disease and cirrhosis. She had been recently discharged from a hospital for a history of variceal bleeding requiring ligation. When the ligation occurred, she actually had some additional bleeding and required an additional banding because of that. However, she managed to stabilize. They had considered a TIPS in her because of this variceal bleed complication, but unfortunately bilirubin was quite high, and so she was discharged and now presented in our endoscopy suite for ligation. So reviewing her blood tests with the fellow, hemoglobin was 8.5, platelet count 34,000, INR 1.5, bilirubin was 5.4, and the question for the fellow was, well, what do we need to do to get this person through her ligation successfully? So thrombocytopenia, as all of you know, is very common in chronic liver disease, and generally defined as less than a platelet count of less than 100,000. And up to 3/4 of individuals with chronic liver disease cirrhosis have thrombocytopenia. It's a reflection of portal hypertension as well as progressive liver disease. Historically, these individuals have been less eligible, not ineligible, but less eligible for elective or surgical diagnostic procedures due to the risk of bleeding. And again, I'm sure everyone in this room has had an encounter with a surgeon, for instance, orthopedic surgeon, neurosurgeon will say, hey, I want the platelet count at 100,000. And the platelet count is usually 40 to 50,000. That's usually not feasible. Also, the presence of thrombocytopenia increases your risk of mortality and increases the risk of poor clinical outcomes, not necessarily because of the platelet count, but because it's a reflection of advanced liver disease. So what causes thrombocytopenia and chronic liver disease? So there are multiple contributing risk factors here. So certainly splenic sequestration due to portal hypertension is a major contributor. But in addition, there's direct marrow suppression due to various viruses, those with alcohol use disorder, iron, certain medicines suppress the platelet count, synthetic pathway as well, the thrombopoietin levels, et cetera. There's also increased destruction. There are sometimes secondary antiplatelet antibodies, and many of these individuals, particularly the platelet count is really low, you need to be thinking that they have portal hypertension with concomitant ITP as well, and they certainly exist concomitantly. There's also fibrinolysis, other types of destruction of platelets, and again, in the setting of cirrhosis, thrombopoietin is just reduced. One of the most important aspects that has become clear over the past decade is that how we determine coagulation is actually not reflective accurately in the setting of cirrhosis, so that changes in procoagulant and anticoagulant pathways in patients with cirrhosis are not accurately captured by the tests we typically order. And these are prothrombin time, the partial thromboplastin time, as well as the platelet count. And so let's just look here because we're talking about platelets in the first column here, but you can see here that we have changes in setting of cirrhosis that promote bleeding, and this is just thrombocytopenia, platelet function defects, you're anemic, so therefore platelet margination is lower. But there are also accompanying with these changes that promote bleeding, there are changes that promote clotting. So you have elevated von Willebrand factors, there's this decreased level of this protease ADMTS13, which is a very important protein that reduces the likelihood of fibrinolysis and increases clot promoting. There's enhanced in vivo platelet activation. You have an activated endothelium. So the net effect is that it is a wash. So the prothrombin time measures the propensity to clot, but then the fibrinolytic pathway is not necessarily reflected. This is also true for coagulation, where you have low factors of all of your procoagulant factors, 2, 7, 9, 10, et cetera, but you also have low levels of protein C and S, which counteract this. Same thing is true for fibrinogen. The same thing is true for fibrinolytic mechanisms. So that when we look at PTT, and CBC, and that's what you see when you're in the endoscopy suite or when you're referring somebody, just know that these don't accurately reflect the ability to maintain hemostasis. There are better hemostasis tests, and the two that are out there that we sometimes order, our hematology colleagues will order for us, are thrombin generation, or some of these whole blood viscoelastic tests. This is TEG or ROTEM, and these can generally capture better the hemostatic mechanisms. But our hematology colleagues said that these have not yet been better validated, and these tests here, this ROTEM thrombin generation, in my opinion, are better served in critically ill individuals in the ICU with whom you're consulting, where you have more ongoing acute clinical issues that have to be addressed rather than an elective procedure. So we can always give platelets, and so the question is, what was the threshold? So some of the just historical background here. So there were some in vitro data that showed that a platelet level for to prevent bleeding was roughly around 55,000, and this was in vitro data that was done in a variety of models, but that is probably where this 50,000 cutoff came from. In addition, there have been some other data. There was a prospective cohort in critically ill individuals with cirrhosis, and they said that 30,000 seemed to be associated with bleeding. Most of the events that occurred here were post-procedure or peri-procedural bleeding events. So 30,000, 55,000. So when we look at our elective procedures, and we need to decide whether or not we need to intervene or not. And the first thing to do is to look at this, which has been this charts have been around for quite some time, but you want to know if your procedure is low risk or high risk. So I have circled over here some of our endoscopic procedures that we commonly have to perform in those who have cirrhosis. So they include endoscopy with or without routine ligation, enteroscopy, colonoscopy with mucosal biopsies, ERCP, capsule endoscopy, EUS, TEEs, and then a variety of other procedures. Versus high-risk procedures include polypectomy, stricture dilation, mucosal resection, balloon-assisted enteroscopy, peg placement, ERCP with sphincterotomy, EUS with FNA. There are a few of these others, or cyst gastrostomy in this setting if you have some kind of pancreatic or pancreatitis sequela here. And so these are the high-risk procedures, which are defined as major bleeding is expected perhaps in greater than 1.5% of procedures. So what do our societies tell you? Because this is an important aspect. So societal guidance has evolved over time. And so these are the current recommendations by the ASLD, the Society for Interventional Radiology, AGA, and the American College of Gastroenterology. So we have platelet count, INR, and fibrinogen here. So you can see the ASLD, which is the most recent guidance, basically said there's no routine procedure correction required for any of them. Okay, so none. Doesn't matter what the platelet count is, doesn't matter what the INR is, doesn't matter what the fibrinogen is. SVIR, a little bit more conservative, platelet count greater than 30, INR less than 2.5, fibrinogen less than 100 or greater than 100. AGA and ACG here are quite similar on the platelet count here for high-risk bleeding, but no routine correction for INR, and they also wanted a fibrinogen level that was above 120. So those are the guidances that you can use, and it helps us because it gives everybody flexibility on what you want to do. And part of this, in my opinion, is actually your comfort level and whether or not you can back yourself up or have colleagues who can back you up if you get into bleeding complications. So let's talk about platelet transfusions for just a minute. We used to do these quite frequently, much less so now. They prevent the risk of bleeding in thrombocytopenic patients, and it's helpful if you have a qualitative platelet dysfunction defect here. And in patients who are actively bleeding, this is something that can help provide hemostasis. However, there are downsides, and again, risk of platelet reactions, these hemolytic febrile reactions, or lung injuries, storage logistics, limited cost life, and importantly, particularly in critically ill patients, you can really volume overload somebody. And to really get a hold of the platelets, particularly some of you I know do consults in the ICU, you'll see they're just pouring platelets in, they're having bleeding, and you just have to try and encourage everybody to get a handle on the amount of intravascular volume you're giving these individuals as you try and settle out a GI bleed or variceal bleed. We do have these thrombopoietin receptor agonists available to us, and these can be useful in elective procedures. I'm going to try and just contextualize how I think they should be incorporated into your practice. These TPOs mimic the effects of thrombopoietin to increase platelet production, and they bind to a different receptor of the portion of the TPO receptor, so it doesn't block your endogenous TPO as well. They also have predictive PK/PD profile, and there are two in the last few years that have been approved for procedures. These are avatrombopag and lusothrombopag. You can see there's another one that's available, but it's for thrombocytopenia and isn't utilized in those who have peri-procedures. So I'll just show you some of the data. Both had very similar phase 3 data. This was avatrombopag here, and they used a dose of 60 milligrams for a low platelet count below 40, and a high platelet count above 40 was 40 milligrams, not 60, given for 5 days. And you can see here there are these very reliable platelet increases here up to 80,000, and then you give it for 5 days, you do your procedure here, but then you have this nice tail here where the platelet count will stay high for a period of time. And in this phase 3 trial, it was well tolerated, no portal vein thromboses, which was something we saw with prior generation elthrombopag when they were given at higher doses, but for a different indication. Lusothrombopag is here, phase 3 design, and you can see here identical. So this was 3 milligrams, platelet count goes up. Again, 2/3 met the primary endpoint of being able to do the procedure without platelets, and it was well tolerated. There were some portal vein thromboses here, which is always a risk with these TPOs if the platelet count gets too high, but there was 1 in the lusothrombopag arm, 2 in the placebo arm, and in general, everybody managed to get their procedures done safely. And again, this is something that you can utilize if you have the appropriate peri-procedural window. You have to know this, but this is something you can utilize to, again, get the platelet count up sufficiently, and at the same time reduce or mitigate your need for a platelet requirement. However, I don't think it's required for everybody, and when we look at the guidances, I think this is sort of a rational approach that we can use to approach individuals whom you see who have thrombocytopenia who require an elective procedure. So the first thing is distinguish whether or not it's a low risk versus a high risk procedure. That's number one. And then number two, some institutions have their own practice guidance. So make sure wherever you are, some people just, it's empiric. They say, hey, everybody who does this needs a platelet count of 50,000. Whatever the guidance is, if it's the guidance, you should abide by it. And then maybe you can have discussions later to see if there's some flexibility here, but check for your local practice guidance. If it's a low risk procedure, then proceed. Don't have to do anything about the platelet count. Of course, meticulous attention to hemostasis is required, but you will find that these individuals don't particularly get into trouble with any type of bleeding complications. However, let's go over here to the high-risk procedures. So here, then, our guidance is, there are a variety of ways that you can approach these depending on which guidances you want to adhere to. So if you want to look at some of the ACG, AGA for high-risk procedure, they would say a platelet count of 50,000. ASLD says we don't really need that. And so I would also assess your comfort level as well. How do I handle this? Well, I look at the prior procedures if available. So the patient that I described, they had a prior bleeding complication. And so this is somebody that you could make a case that, hey, they had a ligation, got into trouble. I would prefer that they have a higher platelet count in case I have the same issue here. Others, if you're experienced and you feel like you can cover yourself, then this is somebody that you may not need to proceed with giving an additional type of intervention such as a TPO or a platelet transfusion. And in general, I tend not to use, if I don't have any complications or I look at what happened here, I tend to go down this pathway here where if there were no bleeding complications, then if I feel comfortable doing the procedure, then, and this can include endoscopy, polypectomy, then I proceed with an elective procedure with attention to hemostasis. If you have to take off a polyp, you just use a hemostatic clip, and that seems to work just fine. If these individuals do get into trouble, then a TPO window procedure with an appropriate window is appropriate. And so for this particular individual, I did go ahead and use a TPO in this particular case just because I looked at the endoscopy reports and they bled. And as it turns out, previously they'd had sclerotherapy, which I think contributed to making the ligation more problematic. Again, we would have normally placed tips, but the bilirubin was quite high, and we didn't have that as a window. But again, I want to stress that's the minority of cases, not the majority of cases. And most of the time, I think in these high-risk procedures, you can proceed with ligation, meticulous attention to hemostasis, and I think you can minimize with your risk of bleeding complications. It's an evolving field, but I think this is a rational approach to minimize our resources, get our patients safely the procedures that they require, and ensure that we can minimize our bleeding complications. I'll stop here, and again, thanks so much for the opportunity to spend the morning with you.
Thank you so much for the great talks. We're going to have some case presentations. These cases are patients that you and I, all of us, have seen in clinic, and they are related to the topics that were presented today. And the goal of this presentation is to try to understand the practice patterns of our experts and try to learn from those. The first presentation, similar to the case that Dr. Paul Coe presented, it's a 59-year-old male referred for elevated ALT, 68. Rest of liver enzymes are normal. Patient has metabolic syndrome, BMI is 36, type 2 diabetes, dyslipidemia, no significant alcohol use history. He's already had a viral hepatitis panel and ferritin and iron panel that are unremarkable. He had an ultrasound that showed hepatic steatosis. So he's been diagnosed as MASLD. and a FIB-4 index was performed, which was 1.22, which is a low probability of having advanced fibrosis. So he's here in the liver clinic, we do the FIB-4, it's 1.22, we recommend all lifestyle interventions, optimal management of his diabetes, a referral to nutrition specialist was placed, the patient was not interested in clinical trial. So in the setting of low FIB-4 index, would you do any additional tests, or would you just discharge this patient from the liver clinic and just have the PCP monitor a FIB-4 every 1 to 2 years? We can start with Dr. Polko.
Sure. So in this setting, so this gentleman looks like he's doing quite well, and he still needs to be followed for his cardiovascular risk factors, but this is somebody that we could reassure. If we had seen him in his office, we might, in addition, just offer him a FibroScan as well, as an extra set of reassurance, particularly if we are going to be sending him back to his PCP. It's always nice to have an extra data point, and actually patients feel more reassured, in my opinion, as well. If you give them, do you have FibroScan in your institution?
Yes, we do.
Yeah.
Yep.
So we would add that, but really the chance that the FibroScan is going to be concordant is actually very high, because FIB-4 has an excellent negative predictive value for advanced fibrosis in this case. So I think we'd be in good shape. And then the other thing is, if you discharge the patient and the PCP monitor, the PCP really needs to monitor. I mean, that's the other thing, because the people can change, et cetera. But if he is getting ready to go on a GLP-1, actually which is a drug that I think will be one of our foundational MASLD drugs in the future, I think he'll be in good shape, and he looks like he has his other cardiovascular risk factors there. And I wouldn't necessarily feel compelled to follow this patient back if he had a reliable PCP follow-up.
Thank you very much, Dr. Kamath.
So I agree with Paul. It's a very good negative predictive value, so less than 1.3 rules out advanced fibrosis. So we don't need to worry about additional testing. This patient's risk of mortality is going to be from cardiovascular disease. He's going to get diabetic nephropathy here. So this patient is better off not being with a gastroenterologist, who's not very good at treating either of these, I think, in there. So the only issue is follow-up. So 56 obese, I would get a FIB score in a year in this patient. So the primary care person can do that. I agree with Paul in general.
Dr. Shetty.
Well, I was just wondering, actually, Paul and Patrick, do you see any role for repeating, you said the FIB-4, what about the FibroScan? If you get an index FibroScan and it's kind of concordant, would you repeat that in a couple of years?
Only if the FIB-4 changes. I think if we know that there's concordance and his platelet count is stay high, then, and you would hope if he goes on a GLP-1 that his ALT is going to fall some. So that I would be inclined, as long as they're concordant, I would be okay following just a FIB-4. But we always leave the caveat in our wrap-up that, if there's some change, you're always welcome to come back.
Fantastic. Thank you so much. So what we have been doing is, if they are sent to our clinic, FIB-4 is less than 1.3, we do the FibroScan the same day. And if that is F0 or F1, then we refer them back to the PCP and have them refer patient back if something changes, so the FIB-4 goes up. So thank you so much for your opinions. And more to the second case, so I'm not going to go over this. Dr. Polko already showed this slide. The second case is a 54-year-old male, again referred for elevated ALT. Rest of liver enzymes normal, metabolic syndrome, platelet count is 202, albumin was normal, ultrasound showed hepatic steatosis, hepatomegaly, mild splenomegaly, the spleen size was about 13 centimeter. I referred to liver clinic. He was actually evaluated by bariatric surgery, and they sent him to the liver clinic for clearance or evaluation prior to gastric bypass surgery. So we diagnosed him as MASLD. Again, his FIB-4 index was indeterminate, 1.57. I did an MRE on him, which showed F3 to F4. The KPA was about 4.3. So in this patient, with the indeterminate FIB-4 MRE showing advanced fibrosis, would you consider a liver biopsy? The second question would be, would you recommend bariatric surgery to patients with advanced fibrosis or cirrhosis? If they are well compensated, child PU class A, And if yes, do you prefer a sleeve or is a gastric bypass acceptable?
Yes, so question here, will you do a liver biopsy? The question again is, will liver biopsy change what you're going to do ultimately? Hopefully, the role of bariatric surgery is going to decrease with good drugs coming around, but this is the situation that we have here. So this is a patient who will benefit from bariatric surgery, will benefit from weight loss. He's got well-compensated liver disease. Even if there's fibrosis, it does not matter. We know that there's significant improvement post-bariatric surgery. My concern is always portal hypertension in these patients. If the CT scan shows no evidence of portal hypertension, that's fine. If you have any concerns, we can measure the pressure. But in general, I would send this patient to surgery. The second question is, what type of surgery do you prefer? So maybe 25 years ago, we worked out that these patients should preferably, if he's got advanced fibrosis, should have a sleeve procedure because they're transplant candidates. Remember, post-transplant, they're going to require biliary procedures. A sleeve is great because any source of bleeding is within the endoscope. You can get that because the rest of the stomach is thrown away. You can do an ERCP post-transplant. That's not a problem. Roux-I, you can bleed from the stomach, which is still left in there, very difficult to reach, very complicated to do an ERCP post. Not impossible, but much more difficult. So our preference is sleeve. The weight loss is slower and lower risk of hepatic decompensation.
So I agree, and I think this person is okay. Platelet count 202,000. I would look at the MRE very carefully to look at their also perihilar varices or just something that would just make it more exciting for the surgeon if they were to go in. But in this particular case, I think you could probably safely go. I wouldn't necessarily do a liver biopsy with the values that you've given here. I personally would try to convince them to do that. Now, some certain surgeons will just demand a liver biopsy because sometimes that's what they do. So sure, if they need it, but I would tell them that it's probably not required. And in this particular case, I agree with sleeve. The other issue is that it's a little bit easier to deal with immunosuppressive drugs that are absorbed post-transplant, as opposed to a Roux gives us some additional challenges.
So the preference of sleeve over Roux-I is because of the concern for cirrhosis?
Well, if he progresses more, yeah. And sleeve has a great track record, in my opinion, in the right setting.
Okay.
Roux-I is, there's very rapid weight loss. And patients with cirrhosis with a rapid weight loss, they can decompensate. Sleeve is a slow weight loss. It's an easier procedure to do, less risk. And like I said, post-transplant, you don't worry too much. And if this patient had decompensated disease at this stage, then what we would do is, at the time of liver transplant, put in a sleeve.
Got it. Fantastic, thank you. So our bariatric protocol that we follow is pretty similar. If a patient has cirrhosis, then our bariatric surgeons and we do a sleeve. We do not do a Roux-I. But if they do not have cirrhosis, then bariatric surgeons usually prefer the bypass surgery. So we had the discussion with our bariatric surgeons. So they wanted to know for sure whether the patient had cirrhosis or not, so that they can decide on sleeve versus bypass. So this patient did end up getting a EUS-guided liver biopsy with portal pressure measurements. The biopsy did show steatohepatitis, but the biopsy was an adequate biopsy. It only showed F1 fibrosis. Biopsy was reviewed with pathologists. There was no evidence of bridging fibrosis or cirrhosis. The portal pressure was only 2 mm of Hg. There was no varices seen on endoscopy as well. So this patient was cleared for bariatric surgery. He did get a Roux-I. Per surgeon's report, liver did not appear cirrhotic. He lost about 50 pounds following his bariatric surgery. His ALT had decreased to 58 at 6-month follow-up. His rest of his liver enzymes and liver function tests remained normal. So case 3, this is a 50. Yeah.
Is this how you routinely do liver biopsies here in the US?
So if I want portal pressures, then we do EUS-guided liver biopsy. If I do not need portal pressures, it's like diagnostic for autoimmune hepatitis, then we do a percutaneous liver biopsy.
Yeah, and EUS can also look in the hilum just to see if they're varices sometimes.
Exactly.
I mean, that's actually the other nice thing about it. It makes the surgeons feel much more comfortable.
Yep. Okay, so case 3, 55-year-old female with ulcerative colitis referred for chronic elevation in alkaline phosphatase. The alkaline phosphatase has been between 125 to 235 over the last 3 years. The GGT was, however, normal, and we also got a 5' nucleotidase, which was also normal. An antimitochondrial antibody was also obtained at the same time as the GGT and the 5' nucleotidase, and that also came back negative. So the question to Dr. Shetty would be, I mean, how would you manage this patient in the setting of a normal GGT and 5' nucleotidase? Would you do further evaluation like an MRCP? Or do we need to check alkaline phosphatase isoenzymes? Or would you get a DEXA scan first and see what the DEXA scan shows?
Yeah, so I think what you're saying here is that the alkaline phosphatase is probably not from the liver, right? That it's a bone cause. And this is the kind of patient who's atypical for PSC, middle-aged woman, etc. So even if the ALK was from a liver source, I think you would want to rule out things like primary biliary cholangitis. In this patient, I think she does need a little bit more of a workup for bone disease. I personally would not check the ALP isoenzymes. I'm not sure what Patrick and Paul would do. And I'm not sure that I would get a MRCP, really. It wouldn't really add anything in this case. I think this woman probably has some kind of bone disease. You know, I'm not sure that osteoporosis itself would explain the elevated alkaline phosphatase, so probably look for another source.
Polko?
So I agree. The other thing, I might do isoenzymes. I'd be curious what her blood group is as well. Okay. Just because sometimes the intestinal isoenzyme can come. But I agree completely that I would not be thinking that this was a biliary source based on the GGT. The ALK-Phos is a canalicular enzyme. That's just an important aspect and misconception. It doesn't come from the bile duct, cuboidal epithelium. It comes from the hepatocyte canaliculus. But again, your other two correlative enzymes are normal. So we need to be thinking that the ALK-Phos is coming out, and I would not be doing any MRCP unless my other evaluation is fruitless.
I agree. Do you know the patient's blood type and whether this was fasting? Because you know, post-prandial it'll rise and everything else will be normal.
Yep. Yeah, no, both some of those labs were fasting, but some were not. This was over the years too, so I'm not 100% sure if all the labs were fasting. Blood type, she was O positive.
You know, the chances that this is biliary is exceedingly low here. And like Kirti said, osteoporosis probably wouldn't give rise. Paget's would. She's a woman, little less likely Paget's, but Paget's would do this.
Okay, thank you. Yeah, so this patient, we did not do any additional liver workup. We repeated actually another alkaline phosphatase and a GGT and in 6 months. And again, the GGT was normal. Alkaline phosphatase was about 150. She did get a bone scan. She did have osteoporosis. She's been started on treatment. But like you all mentioned, because of the normal GGT and the 5' nucleotidase, we did not do any further workup. And I wanted to confirm that that is the approach. Thank you. So last case. Again, this is an important topic that we discuss on thrombocytopenia and procedures. So it's a 46-year-old male, cirrhosis, portal hypertension, history of esophageal variceal bleed. He required band ligation. He did well after the band ligation. He was discharged from the hospital. So he's planned for a repeat endoscopy as an outpatient for surveillance and possible band ligation. His MELD score is 10, bilirubin is 1.4, his INR was 1.2, platelet count is 37,000. His spleen size is 17 centimeter. And his first endoscopy went well. He came in with a bleed, variceal bleed, but he got band ligation and he did very well. So which of the following is recommended prior to his EGD? Now, just to clarify the table that you mentioned, so upper endoscopy with variceal surveillance and band ligation is considered a low risk procedure. So in this patient, would you do platelet transfusion, or would you consider a TPO, or would you just proceed with EGD without a platelet transfusion or TPO agonist?
Yeah, Please proceed. Okay, 3. Yeah, I would do option 3. This one just should be fine. And platelet count's 37,000. As long as, like I said, if they had had a complicated endoscopy, I might reconsider. But in this particular case, everything has gone smoothly. There's no reason to think that the ligation shouldn't be straightforward.
Yep. No, I agree. Just one caution here. So all these data are retrospective, and safety has been shown in these patients. But typically, I know if I see 37,000, I'm not going to let a first-year fellow do this. You know that. So no, I'm serious. The data have come from any time there's a patient who's at higher risk, a more qualified person is doing it. So that, while we say you can do it safely, just be sure someone who knows how to do it is doing it, and this is not their first procedure.
Fantastic. Thank you so much for all those points, and that's it for the day. If you have any questions for our panelists, we can take questions.
So the question here is, patient has hepatorenal syndrome, but you don't have terlipressin. What will you do? We know albumin alone is not effective. What was used before terlipressin in the US and is still being used in many centers is a combination of midodrine and octreotide, which is not a very good combination. Norepinephrine is a good drug. So norepinephrine can be tried. I know at Stanford, there was a study and even norepinephrine was used even outside the intensive care unit. So you have to use a vasoconstrictor, which you have. If your intensive care person is comfortable with norepinephrine, that's a good drug to try. If they're not comfortable and some are not, then it's going to be octreotide and midodrine. Or if the patient can go to a center where they're going to do a transplant, then they're likely to get that there.
Yeah, and midodrine on the floor, midodrine still requires a midline. I mean, so that we had a specialized unit at Stanford we set up because we, terlipressin wasn't yet approved, but it actually worked. It's in the recent couple of trials have shown it's not quite as good as terlipressin, but clearly superior to midodrine octreotide. And if you're going to give octreotide, I like the IV, not sub-Q. But what Dr. Kama said is absolutely correct. It's clearly not as effective as our other vasoconstrictors.